Hello, everyone. This is an off-the-cuff recording that normally these are reserved for my paying subscribers back at peakprosperity.com. This one was too important because in it we have Paul Marik of the FLCCC describing how you can cut your chance of acquiring or developing cancer by 60% or more. So we're releasing this to everybody out there in the public because we want to have your conversation around this. If you want to talk about this more, go into depth, ask me personal questions. All of that can be done at peakprosperity.com. I'd love to see you there. Until then, enjoy this, and I hope you learn from it, and most importantly, take action based on this information. Enjoy, everyone. This is going to be a mind changer, and you know me, I love having my mind changed. So today we're talking with Dr. Paul Marik, who really needs no introduction to most of my crowd, but in case you haven't heard who he is, he was one of the frontline COVID critical care doctors early on. Paul, I think I first surfaced the EVMS protocol that you had, probably was April 2020, looking at repurposed drugs for the care of COVID. And of course, it turns out now you've been proven largely completely correct on all of that. So I serve on the board of the FLCCC, as it's now known, which is an association, Frontline COVID Critical Care Doctor Association, which is out busy with the most famous for their protocols for COVID critical care. Today, we're going to expand that protocol set, and we're talking with Dr. Paul Marik today about a set of cancer guidelines, research that he has done. It's an incredible piece of work. Paul, welcome to the program.
Thanks, Chris. Thanks for having me here. So we're going to be talking about cancer and repurposed drugs. And so this is more like a guidance or a monograph to educate people rather than a specific protocol for people to, treat themselves. So it's always important to remember that you need medical advice and you always want to consult with your primary care doctor before you initiate any kind of treatment.
Absolutely. Absolutely. Of course. And before we go there, though, you're a critical care specialist, and here we're talking about cancer. Two questions, Paul. Can you take us through your arc? Like, who were you? Just so people understand who you are and why we're talking about this and how you got here. Who were you, say, November of 2019, pre-COVID? And what was your COVID experience to get you here to this today? And second question embedded with that, why cancer for a critical care doctor? What's the connection there?
Yeah, so that's a really good question because the journey that I've traveled on since, you're right, December 2019 is not what I would have anticipated, but it has been an interesting journey. So, I was a tenured professor of medicine. I was chief of pulmonary critical care. I worked in the ICU. ICU medicine is very much physiology based. So I think what we did was very evidence based. But I had swallowed the Kool-Aid. I had, believed everything that we were told. I believed what the medical journals wrote. I believed what we were taught at medical school. I believed the narrative. And then COVID came around. And then that was, for me, a great opening, an eye-opener. So I think COVID has shone a bright light onto a really big problem that's been there all the time, but we really didn't see it. And I specifically didn't see it until COVID. And I have many colleagues who were aware of the fraud and the scientific misconduct and the bad behavior of big pharma and the industrial complex. But I was kind of shielded from this. And then so COVID brought along this terrible new era. And it's shone the light really on the enormous corruption and misinformation and scientific dishonesty perpetrated by the medical establishment, unfortunately, I have to say. And so this has been an interesting journey. First it was COVID, and then, I got interested in, related to COVID, treating the vaccine injured, which then took me along this journey of good diet and nutrition and lifestyle changes, because, a lot of what one can do is related to lifestyle. And then it took me onto the path of type 2 diabetes, which I now know is a treatable disease. The establishment wants you to think it's a disease in which you take medication, you get complications, and you're on medicine forever. But that's not true. It's a treatable disease. And then more recently, I became interested in repurposed drugs and metabolic management for cancer. And why? Because I could, because this journey, once you start questioning the status quo, you have to question everything, because you soon realize that everything we've been told and everything we believe in is likely not true. And so, as you'll see, this applies with cancer and cancer treatment. And so this is really important because, it's projected 1 in 3 people are going to develop cancer. Most people know somebody who has cancer. There's someone in the family who has cancer. And so it's a really important subject.
Well, fantastic. And before we go there, I know you've got a presentation that's about a half hour we're going to step through, because that'll probably answer most of my questions and other watchers' questions. I want to take a moment here and plug the FLCCC, because it's donations to that nonprofit organization that allow Paul Marik and his incredible genius to dedicate himself fully to doing this, which is investigating and spelunking in the world of repurposed drugs and asking, hey, if we already have things that work or are known to work, maybe we should look at those. It's more cost effective. In some cases, they are actually more effective. In the case of finding out that type 2 diabetes is actually a treatable condition, not a medicatable in perpetuity condition. It's a big finding. So these are really important things. And by the way, I was just reviewing some stats today, Paul, where people said, but the United States had all these, like, its death from COVID was way worse than other countries. And even if I accept that as true, the next question might be, well, are people in the United States sicker than people on average in other countries that we're comparing against? And I think there's a case to be made for that. And that's the case you're going to be making today. Is that correct?
Yeah. So, what you say is true. The FLCCC is a educational. Our mission is education. We're not selling anything. It's really important to note we don't have any products. We're not selling anything. Our goal is medical education for both healthcare providers and the general public, and just to empower people and healthcare providers to know that there are things that they can do to improve their health, and that healthcare providers can be empowered to help their patients with simple, cheap, cost-effective interventions. So, we're not selling anything, which is really important, so that it allows me to be completely objective and unbiased. And our protocols are available free of charge for download. And you can download them and share them with whoever you like.
And I love the other side of the story, which is educating the consumer side, because often it's the consumers coming to their doctors asking questions and looking for deeper explanations. That part of empowering the consumer in the story is important, because, as you know, not every doctor performed well during COVID. And so the education process goes top down, bottom up. I think both ends.
Absolutely. I think this is a way in which patients can empower and educate their physician. I mean, it's a reversal of roles, but I think it has an important place to play. That patients, nowadays play a much more active role in their treatment, and that they are there to educate their doctors. If they're well-informed patients, they should be educating their doctor. And so it is somewhat a paradigm change.
Yeah. Well, I was talking with somebody just last week who, just on the issue of vitamin D, asked their doctor about it. They're well versed now in the absolute power of vitamin D, and it's a necessity above a certain threshold serum level. And their doctor basically poo-pooed it, and they walked away from that doctor. I suggested they should have run, but it's obvious now that not everybody's up the curve. So help bring us up the curve. So Paul,
yeah, so
I want to go to your presentation now.
I want to just stress what you said. If you can't have this conversation with your physician, discuss such a thing as vitamin D, then I think that is a physician not worth being your primary care doctor. So if you cannot engage in a conversation about really important healthcare issues, if they won't engage with you, then you need to find a real doctor who will have a conversation with you, not just write a script and send you on your way. It's such a really important concept. And I think it empowers patients. They have choices, and they should choose their physician wisely.
Totally agree. All right, let's begin that empowerment process. Paul, take us through your presentation, and then we'll talk about it.
Okay, so just give me a second. I need to start my slideshow. Okay, do you see my slides?
I do. Thank you.
Okay,
Loud and
excellent.
clear.
Okay, so I'm going to be talking about cancer care, the role of repurposed drugs and metabolic interventions for treating cancer. So this is more of a monograph. It's an informational guide rather than a point-by-point protocol. And so, as I said, very important, I have no conflicts of interest. I'm completely unbiased and we're not selling anything. So I can talk the truth. So the sobering thought and why this is important is you can see by this graph that the incidence of cancer, despite improved treatments, improved screening, improvement so-called in lifestyle, the incidence of cancer is increasing. You can see 2019, 20%, and it's estimated by 2030, 1 in 3 people will have a diagnosis of cancer. So it will become the most common cause of disability and death. And so the question is, why is this happening? And we can talk about it. There are really good reasons, lifestyle reasons, why the incidence of cancer is increasing. And so this is projected data from 2023, looking at men on the left and women on the right. 322,000 deaths are expected from cancer. And you can see the common causes: lung, prostate, colorectal, pancreas, liver. And you'll see these are chemotherapy unresponsive tumors. So we're going to talk about this because you have to keep it in perspective. And then in women, again, it's lung, breast, colorectum, pancreas, ovary, about 300,000 deaths. And again, most of these or all of these tumors are chemo poorly responsive. And this will become important. Then if you look at the risk of melanoma, you can see that how, despite improved screening, the risk of melanoma has increased exponentially at an enormous rate over the last 30 years. And then you look at the risk of non-melanoma skin cancer, again, has increased enormously. And so the question is, why is this happening? And I think there's a good reason. This is lifestyle changes. It's obesity, it's insulin resistance, it's processed foods, it's processed sugary drinks, it's vitamin D deficiency, it's lack of exercise. So multiple lifestyle changes are really what's responsible for this increased incidence of cancer. So obviously, just a disclaimer that this is not a standalone guide, that you shouldn't initiate treatment without speaking to your physician. It's important to recognize that this should be used as adjunctive therapy in collaboration with your primary care provider and an oncologist. This should not be seen as a complete alternative. And this is a document which is living. It's going to be continuously updated and refined with time. So these are the traditional cancer treatments. As we know, it's based on surgery, chemotherapy, and radiation therapy. And so conventional chemotherapy and radiotherapy has numerous limitations, which we're going to talk about, and they're listed here. And as we will see, when you have a cancer, the cancer is made up of multiple populations of cells, and chemotherapy and radiotherapy only target the actively dividing cells, which make up about 10% of the cancer population. Secondly, there's something called the cancer stem cell, which is very important because this is the cell which gives rise to the cancer. And conventional chemo and radiotherapy, instead of killing these cancer stem cells, allows them to proliferate. And this is really important. And this is why conventional chemo and radiotherapy fail. Secondly, or thirdly, there's this thing called the tumor microenvironment. So the tumor lives in this environment of inflammation and cells which promote their growth. And conventional chemotherapy promotes this tumor microenvironment. It also promotes the increase in angiogenesis. Angiogenesis is new blood vessel formation. And it's the new blood vessels which allow the cells to metastasize or spread to distant organs. So it increases metastatic potential. And then, of course, it's very toxic. It's toxic to the bone marrow, rapidly dividing cells that aren't cancer. So it's highly toxic and highly costly. And so we then need to move to the conventional theory of cancer, because this becomes important, because treatment is based on the conventional theory. And the conventional theory is that cancer is caused by genetic mutations or genetic instability. So it's primarily a genetic or chromosomal abnormality. And because of this genetic defect or mutation, it drives a population of cells that have the following biological properties. So these cells have sustained proliferative signaling, they evade growth suppressors, they resist cell death so that these cells keep on dividing, they don't undergo cell death by apoptosis. They have replicative immortality, so these cells keep on dividing endlessly. They induce angiogenesis, and they activate invasion and metastases. However, it's likely that this genetic theory is actually not correct. And if that means it's not correct, it means the treatment is based on a theory which is incorrect. And one has to go back to 1924 to actually figure out what's going on. So this is the Warburg effect. It was first described in 1924 by Otto Warburg, who then got the Nobel Prize in Medicine in 1931. And what he found, and this was such a monumental finding, is that cancer cells undergo what's called anaerobic glycolysis. They use glucose as a source of fuel, and they break down the glucose anaerobically. They don't undergo oxidative metabolism in the mitochondria. And that this is a phenomenon which we now know today is characteristic of every tumor cell. It is highly dependent on glucose as a source of fuel, and it has defective mitochondrial oxygenation, so it doesn't use oxygen. And this is known as the Warburg effect. And this is the getting to the metabolic theory of cancer, as we'll see. So this is today we know this is a consistent and reproducible finding in all cancer cells. And this becomes really important in the management of cancer. And so building on these concepts of Dr. Warburg is Dr. Thomas Seyfried, who basically has done an enormous amount of research and written this book called Cancer as a Metabolic Disease. And basically he provides convincing data that cancer is not a genetic or chromosomal disease, but is a disease of disturbed metabolism of the cell. And so if this is the case, then it means the way you treat patients with cancer must be vastly different from the approach based on it being a chromosomal and a genetic disease. So it becomes dealing with the metabolic abnormality of the cancer cell. And so just to support this, I'm going to provide, that cancer is a metabolic, not a genetic disease. There's a book by Travis Christofferson called Tripping Over the Truth, which is a really excellent review on the history and development of treatments for cancer. And basically what he states is no researcher can point to any single mutation or combination of mutations and say with confidence that it alone is the cause of cancer. Nor can any researcher point to a series of cellular systems rendered dysfunctional by mutations and make the same claims with confidence. So basically what he's saying is, and this we know from excellent research, that people have looked at the genomics of cancer and they cannot find a single reproducible, consistent mutation in any single cancer or within the cancer. And then we have this statement by James Watson. People may not know who James Watson is, but James Watson, together with Dr. Crick, was basically who discovered the structure of DNA. He's considered the father of DNA. And he wrote an op-ed, which I think is so instructive. We may have to turn our main focus away from decoding the genetic instructions behind cancer and towards understanding the metabolism within cancer cells. So here's a statement from the father of who invented DNA or discovered DNA, again questioning the genetic or chromosomal theory behind cancer. And then we move to the tumor microenvironment. So as I said, the tumor cells exist in this environment which allows them to proliferate. And there are a bunch of cells. There's the myeloid-derived stem cell. There's a T regulatory cell. There are tumor-associated macrophages and platelets. And these cells actually they're immunosuppressive. They suppress natural killer cells and cytotoxic cells, which is the immune system. So normally your immune system is designed to get rid of these cancer cells. However, we have these cells in the microenvironment which suppress the immune system, suppress natural killer cells and cytotoxic cells, and allow the cancer cells to proliferate. So this very nice drawing by our friend Dr. Mobeen, basically showing the tumor microenvironment. Here you have the tumor cells, and their growth is supported by these Tregs and these myeloid depressive cells, and preventing the interaction of the CD8 cells and the natural killer cells. So the tumor microenvironment is really important in allowing the tumor cells to proliferate. And then, as I spoke about, there's the cancer stem cell. And this is a really important concept. So the cancer stem cell is the cell which gives rise to the cancer. It's the root. And so it's what chemotherapy does is it cuts off the leaves or the branches of the tree, but it leaves the roots unscathed. So it leaves the cancer stem cells untouched and allowed to proliferate. So this is like pruning a tree. So you prune the tree, but you really don't deal with the underlying problem and allow it to proliferate. And so the problem with conventional chemo and radiotherapy is it enhances the stem cells. Whereas, as you'll see, with all the repurposed drugs that we recommend, all of them, without exception, they actually target the cancer stem cell. So they target the rapidly dividing cells, but they target the roots and the stem cell as well. So as I said, cancer is largely a preventable disease. It's estimated that 60 to 80% of cancers are preventable. And so the most important is insulin resistance. So this is obesity, insulin resistance, type 2 diabetes. And as we'll see, insulin promotes the growth of tumor cells. It promotes the tumor microenvironment. And obviously you'll see that the glucose is what drives the cell growth. So insulin resistance plays an important role. And then obviously there's smoking, there's alcohol, vitamin D deficiency. The data implicating vitamin D deficiency in cancer is absolutely overwhelming. It's one of the reasons that people in the northern and southern hemispheres that are beyond a certain latitude have an increased risk of cancer, which is related to decreased ultraviolet B and decreased vitamin D. So there's a strong association between vitamin D deficiency and cancer. And then there's a strong association between processed foods. So processed foods cause insulin resistance, which promotes cancer. Processed foods causes high blood glucose, which then feeds the cancer cell. So through two different mechanisms, processed foods are potently cancerogenic. And we know that sugary drinks and pure fruit juice, along the same pathophysiology, promotes insulin resistance and increases blood glucose. And then surprisingly, exercise and stress reduction are really important, and good quality sleep in reducing the risk of cancer. So there are things people can proactively do to reduce the risk of cancer. And so it's probably best illustrated by this randomized controlled trial. So this is a study which everybody should be talking about. It's the gold standard. It's a randomized controlled trial. As you can see, it was published in 2022 in a reputable peer-reviewed journal. And yet you'll see how important the findings are, and yet no one is talking about it. So what they did is they looked at 3 separate interventions: vitamin D, think it's 2,000 units a day, omega-3 fatty acids, 1 gram a day, and a simple home exercise program to prevent cancer. So you can see vitamin D, omega-3, the exercise program in and of itself, there was a trend towards a reduction in the risk of cancer. When you combine two of the interventions, the risk reduction became even stronger, not quite reaching statistical significance. However, when you combine vitamin D, omega-3, and a simple home exercise program, there was a statistically and exceedingly powerful reduction in the risk of getting cancer. The hazard ratio was 0.39 or 0.4, which means a 60% reduction in the risk of getting cancer by adopting these 3 simple interventions. And this is really very powerful. And so in this slide, we actually build on those findings, because we would recommend a higher dose of vitamin D3. The dose they used was pretty low, a higher dose of omega-3. In addition, if you add green tea, you add melatonin, and you add metformin, you significantly reduce the risk of cancer. So the first 4 are available over the counter, and so really available to anyone. Metformin we would recommend in people who have a strong family history of cancer, they have a genetic predisposition to cancer, or have previously had cancer. There's really good data, as we'll see, that metformin, independent of its effects on blood glucose, reduces the risk of cancer. So what I'm going to go through now is our list of repurposed drugs, which we recommend be considered in patients who have cancer. And so the question is, how did I get to these drugs, and how did I stratify them? So I reviewed over 1,200 peer-reviewed papers. So there is data out there. The point is that this is data which is out there in clear and open sight. So it's not as if this data is hidden. And then what I did is I stratified the effect of the intervention based on a number of criteria, the effectiveness. And so the highest level was a meta-analysis of observational or randomized studies. And we consider observational studies and randomized studies to be of equal weight. And then again, randomized studies and prospective studies, epidemiological studies, case reports, and case series. So in order for one of the interventions really to be higher on the list, we do need clinical data, which is really important, even case series or longitudinal studies, because there is in vivo. So in vivo is experimental data in animal models, and in vitro is in a test tube. So there are these experimental models which demonstrate that these nutraceuticals or repurposed drugs kill cancer cells, they kill stem cells, they act synergistically with chemotherapy and improve the tumor environment. So this is what's a minimum requirement. But in addition, for us to recommend considering a repurposed drug, there needs to be clinical data showing clinical efficacy and safety. And this becomes important because if you're a tool, if the only tool you have is a hammer, the world looks like a nail. So if you go to an oncologist, they're going to give you chemo. If you go to a surgeon, they're going to operate. If you go to an integrated person who uses low-dose naltrexone, they're going to prescribe low-dose naltrexone. And as it so happens, while there is some experimental data for low-dose naltrexone, the clinical data is pretty sparse. So it's really important that we look at the depth of the data, the breadth of the data, and be objective. So we have a list of 20 interventions, 22 actually. These are the top 10 interventions which we recommend. And so that patients can select these out based on their individual preferences and their lifestyle. So number 1 is a low carbohydrate, high fat ketogenic diet, which we'll talk about, which is really important because this glucose and a high carbohydrate diet feed the cancer. There are many oncologists who think that diet and nutrition plays no role in tumor management, cancer management, and unfortunately, they are completely and dead wrong. Then green tea catechins, melatonin is very powerful, vitamin D at a high dose, aiming for a level of around 100 nanograms. It is overwhelming data of both the prophylaxis and therapeutic use of vitamin D. Metformin again, curcumin in the form of nanocurcumin, mebendazole, which is an antiparasitic drug, which is very effective in killing cancer cells, omega-3 fatty acids, berberine, which is a Chinese herb, very good for treatment of diabetes, but also has very potent anti-cancer effects. And then lifestyle interventions such as exercise, which includes both aerobic and anaerobic exercise and stress reduction. So in this
Hey,
list,
Paul, before you move on, can I just ask, the mebendazole and berberine and things like that, are you suggesting these are daily supplements?
yes. So these are people who
Yep.
have cancer. So what
Oh,
we,
okay.
yeah, so this is interventions to control cancer. The previous slide was what people can do, interventions they can do to prevent cancer. You know, the vitamin D, the green tea, the melatonin, and those we recommend for prevention. Now, these are the interventions in people who have cancer. And so, obviously, for people who have cancer, you need a more aggressive protocol with at least 4 or 5 or 6 of these interventions, which can be adjusted to the patient's lifestyle. But the patient would take daily. And then
Okay. One other question then, about the mebendazole, because I know a bunch of people, including my daughter, who went on fenbendazole. Did you distinguish between those two?
yeah, so that's a good question. So there is a gentleman, Mr. Tippins, who had
Hmm.
metastatic lung cancer, who was told he was going to die and there was nothing that could be done. He had a veterinary friend who recommended fembendazole. So fembendazole is a cousin of mebendazole. Mebendazole is what's approved for use in humans. The fembendazole is what's used in veterinary medicine. So he used fembendazole and was cured of his cancer. And so he does recommend the use of fembendazole for treatment of cancer together with curcumin and omega-3s. So we obviously have to be cautious here. So that's why we prefer to use mebendazole, which is the human form of mebendazole, which is FDA approved for use in humans. So although some people may decide to use fembendazole, it's not something we have to be cautious of because it's only approved for veterinary use. And then I should add that you can see the red is metformin and mebendazole. Those are the two which require a prescription. So all these other interventions actually are over-the-counter medication. So just to reiterate, to prevent cancer, we would recommend 2 or 3 or maybe 4 interventions, depending on your risk. But patients who have cancer really need to follow 5 or 6 of these interventions on a daily basis. I hope does that make some sense, Chris?
It does. It does. Thank you for clarifying.
So again, coming back to the Warburg phenomenon. So this is a normal cell which uses glucose and fatty acids to make pyruvate, which then goes into the mitochondria to make ATP. This is called oxidative phosphorylation. Cancer cells, for reasons which we may talk about, have an abnormality of the mitochondrion. And this is Dr. Secret thinks is the primary reason patients develop cancer, is it's a primary metabolic and mitochondrial disease. And so they are unable to utilize pyruvate in the Krebs cycle. And then so pyruvate gets shuttled to lactate and out of the cell. And so this is anaerobic glycolysis, or the Warburg effect. And this becomes really important because, as you can see, the cell is totally dependent on glucose. It cannot use ketones. In fact, ketone bodies actually inhibit the growth of cancer cells. So cancer cells don't like ketones and they like glucose. So what you really need to do to starve the cancer cell is to deprive it of glucose. And that's exactly what Jane McClellan did. She was a therapist who had metastatic cervical cancer. She was told her disease was too advanced and she was going to die. She thought that she was not accepting of this prognosis. So she figured this out herself, how to starve cancer cells. And so through this process of metabolic starving of cells, she cured her cancer, and she's written this book, How to Starve Cancer. And again, it's built on the premise or the work of Dr. Seyfried, in which basically he provides convincing data that cancers are metabolic and not a chromosomal disease, and therefore one needs to treat it metabolically. So the theory is that most of the chromosomal and genetic abnormalities that happen are secondary to the metabolic disease. There are a few exceptions. So there is a cancer called CLL, chronic lymphatic leukemia, which is in fact due to a chromosomal translocation known as the Philadelphia chromosome. So there are some genetic defects which seem to be more important in causing chromosomal dysfunction, but ultimately all cells, malignant cells, have metabolic dysfunction. And so here we have what happens when you take a high glucose load. So if you eat something like a sugary drink or fruit juice, causes a peak in blood glucose. So this provides fuel or food for the cancer cell. In addition, it stimulates the release of insulin. And as we said, insulin promotes the growth of cancer cells. So through these two mechanisms, that a high carbohydrate diet with a high glycemic index really promotes tumor growth and tumor propagation. And so this is well illustrated in the study. So I need to emphasize this was published in the Journal of the National Cancer Institute in 2019. So this is a prestigious journal of the National Cancer Institute. So it's very difficult to disregard this as a throwaway study. And so what did they show? The title is Dietary Insulin Load and Cancer Recurrence and Survival in Patients with Stage 3 Cancer. And basically what they found is that patients who had a resection of the stage 3 cancer, who consumed a highly insulinogenic diet, so it's a diet high in glucose and high in insulin, would increase risk of recurrence and mortality. So this data provides really strong supportive data for those who are going to argue that nutrition and dietary manipulation has no role in patients with cancer. This study strongly supports the idea that that is not correct, and that dietary interventions have an important role in the management of cancer. And so if you look at chemotherapy, there are over about 50 different chemotherapeutic drugs, belong to different classes of agents. And as I said, they all target actively dividing cells. So traditional chemo fails for solid tumors because solid tumors are composed of a heterogeneous population of cells, many of which are slow growing. And so most of the tumors are in the rest phase. The chemotherapy does not improve the cancer microenvironment. It enhances rather than kills the stem cells, and cancer cells become resistant. So you can see why traditional chemotherapy fails in many instances. And so if you compare traditional chemotherapy to the repurposed drugs that we spoke about, the chemotherapy only goes for the actively dividing cells, whereas the repurposed drugs and metabolic management attack all the malignant cells. They're highly selective. They target the stem cells. Most importantly, the effect on the immune system. So you need your immune system, your natural killer cells and your cytotoxic T cells to kill the cancer cells. Unfortunately, chemotherapy suppresses your innate and adaptive immunity by suppressing your bone marrow. So they have vastly different effects on the tumor microenvironment and on the immune system. And of course, chemotherapy is highly toxic with severe side effects and is highly costly, whereas repurposed drugs generally are exceedingly cheap. So when talking about chemotherapy, it's really important to realize that not all cancers are the same. and that chemotherapy targets different groups of cancer. So there is this group of so-called cancer curable. So these are cancers that can be potentially cured with chemotherapy. So these are non-solid tumors. These are the leukemias, the lymphomas, the germ cell tumors and testicular cancer, the lymphomas. So these are non-solid tumors that can potentially be cured with chemotherapy. And so this is important. This would be a group of patients in whom standard chemotherapy would be important. Then there is this group in which the chemotherapy is not curative. What it does do is it prolongs the survival, but obviously at a certain cost. And then there are those in who the tumors are largely unresponsive, and the chemo is used really for palliative purposes only. So it's really important in patients recognize that different tumors respond differently to chemotherapy. So if you look at this graph, these are cancer curable tumors. These are palliative tumors. As one goes across the spectrum, chemotherapy becomes less important, and repurposed drugs have a role in all stages, but particularly as one moves away from cancer curable chemotherapy. And then, of course, there are those cancers that are curable by surgery. And so these are local disease. And by local disease, we mean the cancer is confined to that organ. So if you are fortunate enough to have a local disease that can be completely excised by surgical excision, the prognosis is good. So these are really stage 1 breast, prostate, thyroid, and cancer and melanoma. So obviously, again, chemo has a role, and surgery has a role. So what we're really saying is anyone with patients who have cancer, they need personalized management based on the type of cancer, how far it is extended, the stage, the underlying comorbidities. Repurposed drugs and metabolic therapy really are the cornerstone of treatment. In addition, chemotherapy, surgery do have a role, and then adjunctive therapies such as stress management and sleep are important. So if people would like to see this monograph, they can go to our website, flccc.net. Under the section Medical Evidence on the main menu, they will see reviews and monographs. And so this slide set, as well as this document, is available for download. And Chris, I thank you and your audience for listening to me going on incessantly. Thank you.
Well, thank you. Oh, that was amazing. I have so many questions. My first one is you had this list of in preventing cancer. So I forget, there were 7 or 8 things on it. And then you showed us some data around 3 things: vitamin D, omega-3, and then I believe it was home exercise. Yeah, that paper showed a 60% reduction. What's your, just, I won't hold you to it, but if people did all these things, what do you think is possible in terms of a reduction
60 to 80%.
Cancer incidence?
Yeah, so that's why we said 60 to 80% are preventable. And so I think people who are at a high risk of cancer, there's a strong family history of cancer, they may have a genetic abnormality predisposing, they may have a previous cancer, they should take all 5 of the interventions. And so theoretically, it is a preventable disease. It's a balance between your genetic makeup and your predisposition, and more importantly, the environment. So there are things that people can do, and it's not that difficult. Vitamin D, omega-3 fatty acids, and simple exercise really form the crux of the preventative program. And then if you are at a higher risk, we would add, metformin and some, green tea, maybe some and melatonin.
So let me ask you this. You just said that there is a genetic predisposition. We heard that the BRCA1 and BRCA2 genetic defects, that's what caused the Tomb Raider gal to lop her own breasts off prophylactically, I believe, to preventatively. So there's a genetic component, but you just said it's not a genetic, it's more of a metabolic disease. How do you begin? How do we begin connecting?
So most things in life and most things in medicine aren't clear cut. So it seems there's an interaction between genetics and metabolic disease. So it's not that clear cut, but it's likely these genetic aberrations lead to metabolic dysfunction in the cell. And so in many cases, the metabolic dysfunction causes the chromosomal mutations, but sometimes these genetic predisposition can cause or predispose to the metabolic dysfunction. So there is crosstalk between them. The interesting thing is that, in patients who have the BRCA gene, mastectomy is a pretty aggressive intervention. Is you wonder what the outcome would be if they followed some of these, more aggressive prevention measures that we recommend: vitamin D in high dose, omega-3s, exercise, metformin. You wonder, and the study hasn't been done, but it's possible. So there is a condition called familial adenomatous polyposis, in which people develop polyps in their colon in early age, which can become cancerous. And so again, they recommend colectomy in their 20s, which is cutting out the colon. But there is experimental data that if you use some of these repurposed drugs, you could equally as effectively reduce the risk of cancer. So it does raise the possibility that even those who have these genetic defects that put them at an extremely high risk, that theoretically, and I'm not suggesting this definitively, there may be a role for using these repurposed drugs, because obviously having a double mastectomy or a colectomy is pretty aggressive surgery.
Yeah. So this is news to me too. This is fascinating, and thank you for doing this research. So mitochondria, when I was in med school, I did the first 2 years of med school in my pathology training, and I went off into the lab, and so that first 2 years, mitochondria were never discussed. I mean, they were these things, they were these organelles that you had to understand. That was it, And of course, we knew their role in the Krebs cycle, but more and more, it looks like they're being fingered as being really central to a lot of disease states. And so this is one of them. Is the idea then that people have these genetic predispositions that would then somehow that leads to some cascade that then influences the mitochondria to go off the reservation and go down this pyrolysis?
So it's a good question. There are multiple factors that can interfere with mitochondrial function. One of them is viral infection. We know that there are oncogenic viruses or viruses which cause cancer, SARS-CoV-2 being one of them. And what these viruses have in common is that they damage the mitochondria. We know SARS-CoV-2 causes mitochondrial damage. Secondly, obviously, metabolic dysfunction itself will cause mitochondrial dysfunction, insulin resistance. So it appears to be, and we're still early in this journey. It's not like we figured this out definitively, but it seems that mitochondrial dysfunction may play an important role in the genesis of cancer. And so there are really interesting experiments where if the origin of the cancer was in the chromosomes and the nucleus, then if you took the nucleus of a cancer cell and you put it into a normal cell, then it should become cancerous. And vice versa, if you take the mitochondria from a non-cancerous cell and put it in a cancerous cell, and that's exactly what they've shown, is that it's the mitochondria which transmit the cancer and not the nucleus. So they do these fascinating experiments where if you transplant a nucleus into a non-cancerous cell, it doesn't develop cancer. But if you transplant a mitochondrion from a cancerous cell into a non-cancerous cell, the non-cancerous cell becomes cancerous. So it is astonishingly interesting data. It's not all the dots have not been connected yet, but I'm sure with time, because this is such a paradigm change, that people will do more research to try and figure this out. Obviously, cancer is a really complicated disease. It involves many biochemical pathways, but it is an interesting change in trajectory of our understanding.
So my mind is going a million miles an hour. When I saw you in Dallas at the FLCCC event, you gave a talk on red light, infrared light, near infrared, infrared, and so since then I've been using infrared. By the way, N of one anecdote. 10 years ago, I had this bursitis in my shoulder, really painful. It just kept me up at night. Eventually, I got the corticosteroid shot or cortisone right in the shoulder, and it went away for a long time. So it started back up again. I'm like, oh, I know where this goes. It just gets worse and worse. And I've been putting red light on it, and it hasn't. It's been getting better and better. I don't know, N of one, but now I have to wonder because you told me then that it's the red light is really actually intersecting with mitochondria, and it's boosting their ability to be healthy through complicated mechanisms. But now I'm wondering, this whole northern latitude, maybe we're not only are we not getting vitamin D, maybe our mitochondria aren't getting a little something something.
Yeah, so that's the fascinating question is there's no, as you go closer to the North or South Pole, your risk of cancer goes up and your risk of dementia goes up, the risk of Alzheimer. And so the question is it all vitamin D or is it near infrared? Because obviously you get less near infrared. And so it becomes difficult to disentangle them. But there's no question that near infrared is really good for mitochondrial function. So you could make the argument that, and this is one of the reasons that's paradoxically sunshine and ultraviolet light actually is protective against cancer. So it may be the near infrared. So, just being sun exposed, or if you can't be sun exposed using a sun lamp, may reduce your risk. The problem is, this is hypothetical. There's really not really good data, but it is theoretically within the realm of possibility. The same would apply to methylene blue, which acts to improve mitochondrial function. So methylene blue may have a role in both the prevention and treatment of cancer. But nobody has that I know of has investigated this in the kind of depth that we would require. So that's what I said. We're on a journey. The journey I think has just begun. We're beginning to understand that cancer was not maybe all we thought it was. And so that this raises a whole host of new possibilities and new interventions.
Wow. So that's the theory. So if you run across all these things, tell people about what you do in your own life and the what benefits you think you've noted. Again, anecdote, N of one, but what about your own journey?
So I think an anecdote is important because it builds on your clinical experience. It's not good enough it's not science. So you can't publish based on anecdotes. You have to publish your data. But I certainly believe that, I do photobiomodulation. I think it's really important for improving, my mentation, my cognition, my general sense of well-being. And so I have a near infrared sauna that I concocted. So there's really good data that, for example, sauna is we know from the Finnish experience that people who sauna 3 times a week have a decreased risk of all-cause mortality, decreased risk of cardiovascular disease, decreased risk of depression. So we know sauna is good. And if you add to that infrared, you're having the double whammy of the infrared radiation as well as the thermal stimulus. So there are some interesting things that one can do that are considered, non-traditional. But there's really good data in terms of, not in cancer, but in treatment of depression, treatment of COVID-19, and many other diseases.
Well, I love the anecdotes because they actually make a lot. This is how we learn, and of course, the gentleman who figured out that H. pylori was actually what was causing ulcers, not excess stomach acid, gave himself anecdote style ulcers and then cured it with antibiotics. Making a very famous sort of a self-experimental case to make his case. Having a hard time driving that lesson home within his medical community. It was like, yeah, we don't want to hear this crazy talk. So in the time we have left, though, I want to turn now to this idea that, look, you've surfaced a lot of things. It's very clear that there's a huge signal there that would be very positive, and yet we don't hear about these things on CNBC, and the NIH certainly doesn't send me flyers telling me to take vitamin D. None of that's happening. How do you explain that?
Yeah, so you talk about vitamin D because the data on vitamin D is overwhelming. I mean, it's just so substantial. It was even reviewed in the New England Journal of Medicine, which is considered the journal in 2003, I think, in which they basically state that vitamin D prevents cancer. So this data is available. And so the question is, why don't doctors know about it? Why doesn't the general public know? And I think the answer is pretty obvious, is that you can't patent vitamin D. The same way as you can't patent sunshine. So nobody's going to make money out of this. And unless you can make money, there's no financial incentive or financial goal in popularizing this. So it comes down to, the big pharma's control of the medical establishment, is that these are simple, cheap interventions, simple and cheap. And obviously, if we reduce the risk of cancer by 60 to 80%, the economic implications to the healthcare system would be enormous, because this is a $200 billion industry. And so that would be threatened. So I think they are enormous, although people don't want to talk about it, they're enormously powerful economic reasons why this data is being suppressed.
Yeah, unfortunately. And that's one of my key learnings from COVID. It really taught me the power of that. I didn't appreciate it. And I'm not even sure I still fully appreciate it, but I now see it for what it is. And as I said, I used to read science papers, abstract methods, results, down that order. Now I skip straight to the author associations and affiliations. And I confess, Paul, I don't read things that come from conflicted organizations anymore, because I just know that if I dig into it long enough, I'm going to find all their biases, and it just annoys me. So I've actually, maybe it's not right, maybe I'm throwing out some baby with the bathwater, but it's certainly skinny down my reading chores.
Yeah, no, I agree with you. If there's a potential conflict of interest, there's a conflict of interest, and you have to question the validity and accuracy of the data. So you're absolutely true, particularly if it's a study funded by pharma or big industry. You have to seriously question the accuracy, the validity, and the scientific, credibility of the data.
Mhm. No, I agree. So this is incredible work. And of course, we'll tell people how to find it in just a second. Um, this is a living document, so I trust you're going to be updating this over time, as you say. But what's next? What are you working on now?
Yeah, so it's even a more interesting topic, and that is depression,
Hmm.
because it's a common disease. Maybe 20% of the population are on antidepressants. The reality is that the traditional SSRIs, serotonin reuptake inhibitors, essentially don't work. They're highly ineffective. They don't work in about 70% of people with depression. And the reality is that there are a whole bunch of cheap repurposed drugs that are highly effective for the treatment of depression. So again, it's the same story over and over again. We have a common disease which is being treated with drugs that are expensive, that are pharma driven, and for which you're on forever and have limited efficacy. And then on the other hand, you have repurposed drugs which are highly effective. And so this is my next project, which I think will be as interesting and probably as useful, because depression is a common medical problem.
Well, thank you so much for that future work. Thank you for this work, all your past work. I'm a huge fan, huge consumer of it. You've changed my mind on a number of things over and over again, and that's something I personally value very, very highly. I love having my mind changed, or opened rather. I thought I knew stuff, but the older I get, the less I know for sure. So it's great to have you there, digging through all those hundreds, if not thousands, of papers to sift through and find some signal in there. So great work. Thank you so much for
Sure.
that.
I mean,
And
that what you say is really true. The more you know, the more you realize how little you really know and how much more you need to know. It never ends.
yes, it never ends. It just grows exponentially. So, Paul, how can people find this monograph and all your incredible other protocols?
Yeah, so if they go to the flccc.net, we have a tab for protocols, we have a tab for medical evidence, and they can download these protocols and this monograph. We are going to have the monograph made into a Kindle as well as a book, so it will be eventually available for download from Amazon, both as a Kindle form and in a book form, but that is still a few months away.
Excellent. Well, thank you for that. Thank you for everything you do. Thank you for your time today. Really appreciate all three of those things.
Thanks, Chris. Thanks for having me on, and thanks for what you do. You provide a window to the rest of the world.
My pleasure. It's just what I was born to do, just like you're doing what you were born to do, I feel. So good combination there. So thanks again.
Thanks, eh?